Welcome. We're going to give a minute for people to enter. All right, well, I think we should go ahead and get started. Welcome everyone to today's panel. What will it take to create and scale a home-based care ecosystem? This is our first panel of the year for the Conversations on the Business of Health webinar series. The series is hosted by the Hopkins Business of Health Initiative, or HBHI. I'm Dan Polsky, director of HBHI, where we focus on the role of business and incentives in advancing an affordable and equitable high-value health system. I'm going to turn over the proceedings to our moderator and HBHI expert on today's topic, Bruce Leff, Professor of Medicine and Transformative Geriatric Research in the Division of Geriatric Medicine. I'm just a delightful person all around. I'll turn it over to you, Bruce. Thank you for putting
Thanks,
this all
Dan.
together.
Don't think anyone's ever described me as a delightful person all around, but I will take that and work with that. It's really a great pleasure to be here with three really brilliant colleagues and friends, and we're going to spend some time talking about this notion of a home-based care ecosystem. So I'm just going to have a few framing remarks on what we mean by that. Then I'm going to ask my friends here to introduce themselves and be a little bit boastful about their experience and expertise in the area, and then we'll get started with some panel discussion. Feel free to use the Q&A function during the discussion to pitch questions, and we can try and work them into the flow of the webinar. So just a word about a home-based care ecosystem. So I'm a geriatrician and health services researcher. This past week, I hit my 30-year mark on faculty at Hopkins. My research, I still see patients, but my research has really been focused mostly on development, evaluation, dissemination of innovative models of healthcare delivery for older adults, really mostly focused on home and the community space. So models like home-based primary care, hospital at home, skilled nursing facility care at home, models like that. A few years back, my colleague Christine Ritchie, who's a geriatrician and palliative medicine physician at Mass General, and I had a paper in Health Affairs where we made a case for this notion of a home-based care ecosystem. That is, over the years, a slew of models have been developed, proven, decent evidence base for models that provide care in the home and the community, and models both without, some social models. Think about home and community-based services, long-term services and supports, and then including medical models like home-based primary care, home-based palliative care, skilled home health care, hospital at home, skilled nursing facility care at home, more recently, emergency department care at home. And you can think of these models arrayed both on an axis of models that have little, going from little or no to models that have a lot of medical input, and models that are more of a chronic longitudinal focus towards models, say, like hospital at home, providing acute hospital level care in the home as episodic models. And our thesis was that, given the evidence base for all of these models, that it might be reasonable to start to think about a future state where, say, under a total cost of care model, entities could start to combine and create a full spectrum of care that is centered around the patient in their home. So today's a normal day. We provide, maybe the patient doesn't need any care today. Then they get a primary care visit next week. A few weeks later, they develop an acute illness and they need hospital at home. Okay, today is a hospital at home day. 3 days later, they're doing fine. We switch over to, skilled rehab at home, and the patient doesn't necessarily need to move. The responsible entity is operating in a total cost of care model, making care decisions, and the patient hopefully would avoid lots of care transitions, which can be harmful, and the harm that sometimes comes from being in facilities. So that was something of the vision. When we submitted that paper to Health Affairs, we were accused of being, on mushrooms and hallucinating a bit, but ultimately the paper was published. And today we're going to hear and have a discussion with three of my colleagues who've, I think, also been thinking about this at some depth and are actually trying to live this and implement at some level these kinds of approaches. So I'm just going to ask each of them to introduce themselves, to be a bit boastful, and maybe just in a few words talk about, give some sense of, why care in the home might be preferred in your experience, and any high-level thoughts on this notion of an ecosystem. Fantasy, reality, just to get the discussion started. Why don't we start with Pippa?
I was waiting to see who was going to get it. On the paper, it was one way, and I thought Bruce might come to me first, so I should have been more ready. Thank you, Bruce. And thank you to Johns Hopkins. And this is a wonderful gathering, and I'm excited about having a conversation with some of my favorite colleagues and friends. I'm Pippa Shulman. I'm the Chief Strategy Officer and Chief Medical Officer of Medically Home. And Medically Home is a company that helps enable health systems, payers, and payer providers to provide all kinds of acute care in the home. Our core business, what we started with, was hospital at home. That's what we're best known for. And over the last 6 years, we've helped provide care for more than 40,000 patients in 20 states. Now, the vast majority of that happening in the last few years, but we did start slowly, quite some time ago. As Bruce said, we've really thought about this notion of a continuum of acute care. What else can you bring to the home? Once you can do hospital at home, right? Once you can deliver on-demand care at 2:00 in the morning for someone who is a very acutely ill, and you can do it immediately, well, that opens up a whole lot of opportunity. Can you deliver an episode of acute care, so urgent or emergent care? Can you respond when the patient has an acute issue to, someone maybe on a home monitoring program, but who needs something right now? So often patients in home-based care programs have an acute need, and we end up sending them into hospital because there isn't a way to respond. And so one of the things Medically Home is really thinking about as we evolve is how can we respond across a continuum? And so we've piloted and worked on and SNF at home, ED at home, and other kinds of care model. But we've really focused on the hospital at home, and lots of use cases from post-surgical to bread and butter medical, post-surgical cases in the home. I came to this because I was a primary care physician and hospice and palliative medicine doctor. And I really, since training, when I saw the harm that the hospital could do to my patients, when I went to a wonderful training program that allowed me to carry a panel of home-based primary care patients, and I saw the power of being able to provide care in someone's home across, the span of their life, have really wanted to see how far we could push that continuum and what we could do. And so and every time I talk about home-based care medicine, someone comes up to me and says, oh, I did this for my mom, or I did this for my grandfather, I did this for my brother, or do you know someone who could do this for my family member? Doctors and nurses have done this for their family, and everyone else wants this for their family. And so everyone wants more of this. There isn't enough. And as a system, we don't know how to pay for it. We don't know how to sort of equitably distribute it or who to apply to. So that's why I'm really excited to have this conversation, because I think when we talk about all of these opportunities to provide care in the home, we still, even after all these years and all this study and all this wonderful data, we don't quite know how to apply it well. And I think we're learning a ton, and I'm really excited to share what we know and to have this conversation. So thanks, Bruce.
Thanks, Pippa. Ali?
Thanks, Bruce. And again, thanks for having us. I'm Ali Khan. I'm a practicing general internist these days on the west side of Chicago at Oak Street Health. More critically, I am the chief medical officer at Aetna Medicare, serving our 4.2 million Medicare and dual eligible enrollees and our 11 million medical supplemental enrollees across the country, and really thinking critically about what is that clinical strategy? How do we deliver that from a clinical operations perspective? And how do we make the complex simple when working with partners like Pippa and like Chris in terms of doing that work most effectively and critically in the time sequence that's required to actually build trust that keeps someone stable at home, right? I come to this work after 15 years of sort of building models like these in the wild, having spent a long time in home-based primary care, home-based wraparound care, intensive SNF based primary care models, and a few in hospital home models at places like Iora Health, CareMore Health Plan, and most recently at Oak Street Health, where I was privileged to serve for the past 5 years in medical leadership, including the last 3 as chief medical officer. And so what I'll tell you from that work is that, this is incredibly critical. And, having learned from national luminaries like Sophia Chang and George Fields, Peter Bowling, Charlotte O'Brien, and others, home care by definition is the omni-channel that we actually need, right? It is a mix of digital, analog, and shoe leather care that seeks to become a single source of truth. And at Aetna, I would say we really fervently believe that the path forward in actually driving real clinical outcomes and impact for folks who are classically homebound, functionally homebound, just in need of something more, and whether armed with the resources to handle that or in need of real socio-demographic support, that at-home ecosystem that we'll talk about today is how we really enable that kind of last mile proactive care delivery that our members just deserve, right? It's the kind of care we'd want for our parents and grandparents, put very simply. And so I think as we get into the discussion today, where I'm really interested in us digging in is, that care has to be more than the silos that sort of exist today, sort of driven by reactions to payment models, right? Sort of acute at home versus SNF at home versus ER at home. You often find that folks like Chris in the wraparound and attributed primary care models at home are doing all those things anyway, but just not labeling it, right? Because it's the right thing to do. How do we get to a place where we're doing what's right to do and we really just give a crud at home, right? What are the technical and tactical best practices and playbooks we have to disseminate to get that to scale? And then as a plan, I think really deeply about what do I do as I shift from reactive to proactive to actually enable that to happen quickly and in real time, using tools like authorizations, using tools like network design, using tools like, just sharing phone numbers, right? Stuff like that, to get engagement and an activation to a place where we're not building models that predicate on 30% of people being engaged, but that we get to 100%. So excited for today's discussion.
Thanks, Ellie. Chris?
Great. Thanks, Bruce. Again, to reiterate it, it's great to be invited. Bruce, thank you for having us. It's always great to be with Pippa and Ollie, and Dan, thanks too for kicking us off. So good afternoon and good morning, everyone. I'm Chris. I'm an internist, a hospice and palliative care physician. I've been really fortunate that the clinical work that I've done post training has been as a home care doctor, so a primary and palliative care doctor in New York City and Long Island. And I've had the great fortune as well of being asked to build home-based medical care programs, whether it's on the provider side at Northwell, where I was the head of an independence at home demonstration site where we showed almost over 30% medical expense reduction while improving quality. And then over the last 5 years, I've been on the for-profit side at companies like Landmark and Optum at Home, serving as a chief medical officer, where we've been working to bring home-based medical care services to Medicare Advantage and D-SNP patients at a scale that has been both exciting and very challenging. We served patients in 35 states and had an average daily census of about 150,000 patients, and with thousands of providers and cars doing work that we hope is really, really good for patients. And so, I got my start in this or got interested in this space, mostly, I think, out of many as many have due to family. I come from this large, Italian Catholic family from Long Island, and I had, dozens of great aunts and great uncles. And I saw as I went through high school and college and then medical school that it was increasingly clear that as they hurdled 80, 85, 90, the care that they needed was not available in the community. And so was fortunate to be training at Mount Sinai, where they had a truly innovative and leader in the field home-based medical care program that was started by Jeremy Bowl, and saw for the first time the thing that my great aunts and great uncles and great grandparents needed, and really got excited about that and decided that this was a place to spend a career. And so I've been doing that for the last 15 years. And I think that, I do appreciate and agree with the comments that Pippa and Ali brought. And I want to add, The thing that I think a lot about as we think about this home ecosystem, which I think I'm just going to put aside that we all agree that there is a need for care to be brought to the home for a subset of patients. And we can talk offline if there's somebody who disagrees with that. But I think the word that we all need to keep repeating is discipline. Discipline, discipline, discipline. And we're going to talk about it in the comments and questions that are coming up, because I think that it is a little bit of a boundaryless concept. Care in the home for who? Well, that's really important. The for who is incredibly important. If we get the wrong patients in, we won't have a financially sustainable model. The what or the how, what are the processes? What are the parts of the clinical model? While we certainly have a lot more to learn, we also have learned a lot over the last 20 years. And, and Bruce, I congratulate you on being at the forefront of collecting, publishing, researching the what of the home care ecosystem. And so I think that as an industry, we need to do a couple of things. Stop doing things that don't work. Like, just let's start there, right? We operationalize a lot of things that are easy to put into the field that don't actually reduce medical expense or improve quality, and really focus on the things that we know are key ingredients for success in a home care model of care. And we're going to talk about those various different things over the next 45 minutes. So I'll stop there, Bruce, and I'll turn it back to you.
Great. Well, we all agree. We think we all agree, and we'll hear if people don't agree with us, hopefully in the Q&A. And by the way, the Q&A is open, so feel free to pitch questions. So maybe we'll just move on to this notion. And Chris, I'd love to pick up on this notion of things that don't work that are very commonly done because they are maybe not, we say something is easy, even easy things aren't easy, but they are easier than other things. I'm just wondering what sorts of things are on your list of things that don't work, say, for a population that we might be thinking would be appropriate from the ecosystem. And then I'm going to pull in Pippa and Ali thinking about how do we think about targeting or selecting the right patients for these kinds of home-based care interventions. So what are some of the things on your list that you were thinking about when you said things that don't work? Is that like chronic disease management, or what sorts of things?
Well, Bruce and I, you and I have had this conversation for a while. I think the list is clear because the literature's been published, right? And the data's out there. So things that don't work particularly well. And I just want to be clear. I'm talking about complex patients with advanced illness who require care in the home, not a newly diagnosed diabetic. Like, disease management programs typically don't work in the populations we're talking about. The complexity of the patients overwhelm a disease management program because the disease is so interrelated to the other diseases and the socioeconomic needs of that patient. I think the biggest thing we need to continue to stop doing is thinking that we can substitute face-to-face with telephonic. We all work for companies these days that have been financially stressed, and the reflex thing that many companies do is say, okay, your care model costs $400 PMPM. We need to get the cost down, 12%. And so as you start that exercise, you start to make little compromises, and those little compromises seem innocuous in each individual decision, but they sort of add up over time. And one of them is like, we can just do telephonic visits, or we can do, in my last role, we have this lively debate about initial visits done with video, right? Because video is almost as good as in person, right? And you do that, and you do it as an experiment, and then you realize 6 months later that, the persistency of patients in your program has dropped in half because they thought that initial video visit was a complete waste of time, and they don't want to ever talk to you ever again. And so I think that there are things that have been shown in the literature that don't work. And I think one other thing that hasn't been talked about, but I will just offer it up as an area for potential study, is we all talk about in this space interdisciplinary teams. And I think we all recognize that you need multiple viewpoints, multiple skill sets in the care of complex patients. But in my journey over the last several years, what I've also seen is that the interdisciplinary team and the top of license mantra of like everybody has to be at the top of license means that you continue to add complexity to your care model. And what happens as you add complexity is you have overlapping role types, you have managers for each role type, you're adding cost, you're also adding a diffusion of responsibility, which is probably not helpful to the ultimate goal of taking responsibility for a patient, a group of patients, and outcomes. And so I think one of the other things we need to really think about as we're things to not do is to make our models overly complex with different role types to solve each and every new problem. Each and every new problem with a new role type made sense in isolation, but the sort of ballooning of role types, managers, and cost is, I think, really potentially detrimental to outcomes.
Can I follow that up for a sec? Because I like want to like it by 500 times. But I think that this point is actually incredibly important, because where it comes from is, again, I would argue it stems from a fee-for-service mindset and a like sort of the trauma of what the healthcare workforce has been through, right? Like, we sort of say, well, this is in scope of practice, this is not, right? Like, so I need to add these people. We got to do things. Of course, I need a diabetes educator, certified educator, and I'm like, yes, and there are lots of ways to teach someone how to like educate on diabetes. I was very lucky to spend the formative years of my career with Rashika Fernandez-Poulet at Iora Health, where we talked a lot and really spent a lot of time in a community health worker promotora driven primary care model that had some in-home pieces of looking for people who are excited to operate at the top and bottom of their licenses, right? And not because of the cost containment measure, but that like my most effective role as a primary care physician is more likely as a social worker than anything else. And because what is the point, to Chris's other piece, is that in a world where many of the patients that we take care of, particularly those in an advanced illness, complex medical, social, and behavioral pathology, dealing with a lot of issues, right? And like with a history of worrying about them alone, by and large, we have to undo the scar tissue of mistrust in a broader system and in humans, right? And so that work is sometimes bovied, right? But a lot of times it's blunt dissection. And that blunt dissection is fastest when you actually show up to where someone lives, build some actual therapeutic alliance over a period of time, and which may not be the first time, right? Which may be visit 11, as we all know, and then go forward, right? So like, I think this is where I think we're seeing an interesting place emerge in some additional models and in and around where they are like models like Waymark or a Company Health or others, that a City Block kind of did some of this progenitor work, which says, hey, perhaps it is that community health worker is really at the center because for that exact reason. And like, there is not as much classical sort of like top of license clinician that we may need. But what we really need is a team where that CHW then is the conduit in and around pharmacy interventions, behavioral health interventions, and classical, community social work, building a longitudinal plan that drives follow through, right? When we do our work well, that's what all of us do. But, because of exactly what Chris is saying in terms of like, asset creep of just like saying, well, of course I need a manager for this. Of course, I need a position leader for that. And someone needs to develop the training versus being like, what are we here to do? And how are we spending time from an infrastructure perspective, getting our teams really good at focusing on a member's needs, making sure they don't fall through the cracks, action planning, and actually doing the follow through on the actions that gets them there. And then recognizing the dynamism of that, of those roles centered around a common mission and purpose, and with the right performance measures and sort of ratios to get that to work. We revert a lot to our status quo, and medicine, healthcare delivery operates in that status quo that Chris offered so many times, especially for those of us who are all trained in health systems. That pushing past that becomes really the big challenge, the big hurdle. And I think it'll be interesting to monitor some of these, physician and nurse light models to see what they teach us.
Thanks, Ellie. Pip, I don't know if you want to comment on that or.
I think this conversation on workforce is so important, because the other end of this too is if we don't expand the thinking on who can do these jobs, whether it's community health workers, whether it's, in some care models, paramedics do incredible work when you think about what are the jobs to be done, and I loved, Ali, you said the top and bottom of license, right? And I think every one of us on this call have cut someone's toenails at some point or another in a patient visit. That's something that one of my mentors said, like, if you can't get on the floor and cut your patient's toenails, like, what kind of physician are you? But someone would argue that is not top of my license. But I think top and bottom of license for every member of the team. But what does your patient actually need? There's a lot of talk in the sort of technology and product world, like, are you solving the right problem? We have to think about for our patients the same exact thing. And if we don't broaden that workforce and we don't think about this differently, we are just creating the same shortages and the same burnout problems that we have in our bricks and mortar facilities. We haven't actually transformed the system in any great way. And I think what we have seen is where you create new opportunities and new ways to work that people actually want to apply for these jobs. They want to work in these settings. And the patients are so much happier with the care that they're getting over a period of time from someone who's happy in their work. But it might not look like what the original job description for that clinical role was when they first got out of school.
Thanks, Pippa. Let's shift gears slightly. I want to come back. Chris had mentioned discipline, and I want to just sort of tie discipline and a question that came up earlier around this notion of, who are we doing this for, selecting the right patients. And maybe if someone wants to try and tie those issues together, this notion of, when as a health services researcher, I always think of, target population, intervention, and the outcomes you're willing to live or die for. And when you line those things up, world peace ensues. And when you don't line things up, you waste a lot of money, a lot of time, and you don't get what you're hoping for. But I'm just wondering if anyone wants to comment on this notion of, selecting the right patients and that notion of discipline. And maybe I'm going to toss it back to Chris, because I know this is an interest.
Ready to jump in. Go for it, Chris.
Yeah. Here we go. Go for it, Chris.
Well, we're all laughing because we've all been burned by patient selection criteria that are either off or more likely too wide, I guess, would be what I've experienced. I think getting back to the data, right? There's fairly good data that you can put high intensity care models that bring care to the home to build trust with patients and families. But they have to target a pretty sick cohort of patients. And it shouldn't be your top 20% of patients, because your cost structure, even if you're using community health workers as a big part of your model, your cost structure is such that there's not enough medical expense to reduce. And so the simplest thing is, we are all running businesses here. We all want to be able to scale our businesses. The only way we can scale our businesses is on a sound financial model. And so I think that a lot of companies have found themselves in trouble, particularly with the recalibration of the revenue through risk score capture, of having been designed for a future sale. And so their job is to take risk or responsibility for as many patients as possible, because that increases either the revenue that you're getting or the number of lives that you're responsible for. Either things are good for future transactions. And what happens is that when you really subject these programs to real methodologic or rigorous scrutiny, what you'll see is that the less sick portion of these broad cohorts wash out the impact that you're having on the sicker patients. And so then you're vulnerable to being the baby thrown out with the bathwater of, like, the whole contract looks like it's underperforming. The reality of it is it's underperforming on the healthier patients, and you're doing reasonably well on the sicker patients. And so I think discipline around making sure that we're applying what we know about who has high enough durable medical expense that has reducible portions of it, that you can then build a business around a higher intensity care model, which is just a euphemism for something that's more expensive than fee for service.
I would add, I think, a couple of things. I'd underscore what Chris said about the unit economic discipline, right? Which is different than revenue discipline, in that, like, many of us coming from traditional health systems think about RVUs, we think about, DRGs, we think about those sorts of things. But unit economic discipline really says, hey, like, to Chris's exact point, when I am paying a primary care physician or, a geriatrician $270,000, but in a home-based model, at best, I could maybe extract 8 visits a day, right? Maybe. And most of the models that I have built over the years actually have never presumed that, because we haven't had necessarily the operational and supply chain rigor to be, and like geo density to be able to actually deliver that, right? That like when you take that versus like somebody's normal mental math of like 25 visits a day in a fee for service setting, or even 12 to 14 visits a day at Oak Street or Iora, right, in the brick and mortar setting, that unit economics is different, right? And you have to apply that to every certain member of the team, and then realizing, okay, then what do I need to do, right? Chris is right that revenue optimization has been a decent part of this over the last 15 years of our field, because of the nature of Medicare Advantage and dual eligible plans. What we are seeing now, obviously, at this moment from a policy and regulatory perspective, is that the need to really lean in, to Chris's point, again, I'm just reiterating everything, on actual total cost of care impact, actual clinical outcomes, actual restoration of dignity through great end-of-life care, right? It becomes really critical. And so one says, what is the set of programs, and how does that shift and evolve? And where do we go, right? So we may have all been doing acute care at home on the side without calling it out. But now what does it mean to say, do I have to follow like what Quick Medic or Medically Home does and have a floating team available at all times to do that? So that doesn't, divert my primary care folks from doing what they need to do to see patients, right? But you have to balance that against the flip side of a bunch of our clinicians, and Pippa probably hears this a lot, who come to us, really see value in being able to go meet that member in that acute moment, right? So like there's an operations piece that gets very complicated. So putting all that together is sort of one real challenge. And I think when we think about this, in aggregate, I think then as a plan, for me, it becomes, what am I doing? I can't sit here and just be like, okay, I handed, 40,000 people to Chris and here we go, right? But it becomes, what am I doing to make Chris's life easier, right? So if Chris's member shows up at Yale New Haven Hospital, and like we know that Pippa's team is at Yale New Haven Hospital, how have I already auto-authed Pippa's team so that they can go do acute care at home before they hand back to Chris's team, right? Now we can have a whole debate about whether that should happen, but like to point, like it's like as a plan, what do I enable, right? As a plan, how do I make the complex simple? As a plan, how do I lean in proactively in that same mindset of longitudinal integrated clinical care management, utilization management, to drive all the things that we want to have happen? I think that becomes a real part of the opportunity here because of those regulatory pressures. I'll say one last thing on population. I think Chris is exactly right. I will tell you, my thinking on this has evolved over time, coming from a high cost, high need sort of background, and where that I think there's still a lot of merit in that approach if you can narrow it precisely where it needs to be. I will also say that I think we have spent a lot of time at CVS, and particularly at Oak Street, on saying, and especially in our own randomized control trials, is the right population actually frail elders, right? Which has overlap, but is somewhat distinguishable from a classical high cost, high needs complex population. And so like the models are very similar by and large, but is it more that you have that like really top percent, right, that didn't wash out, and frailty next to each other, as opposed to the folks that didn't wash out and the folks who are washing out, right? When we look at this from a cost lens or a utilization lens. So I'll leave that there.
Pippa, did you want to add anything to that?
No, look, I think this is, I would love to be able to spice this up, but I think it's a great conversation. I also think it's important to understand that, there's things we can offer to lots of different groups of patients, and being able to understand the needs of each patient, that's the kind of population that we're trying to address here. I think, Bruce, you and engaged in a great amount of work with the World Congress on Hospital at Home, really to just define what is hospital at home, because there was not agreement on that, right? Is it after you are discharged from the hospital and then we go watch you at home, or is it truly substituting the hospital care that is provided in a bricks and mortar hospital for hospital care that's provided in the home, or some amalgam in between? Because otherwise we're sort of talking apples to apples. And is it only for frail elders who need care in the home, or is it for anyone who would require hospital care? And we believe that can be safely provided in a bricks and mortar hospital at any age, children or adults, and I think broadly applied. But we also know that it's really difficult to offer in-home care to the entire population. We can't support that, right? It's very nice for consumers, but having the expectation that you can call and be seen in the home on demand for low acuity issues, I don't think is the right expectation to be giving to the general public. Now, that might be very appropriate for a telephonic visit or a telemedical visit, a video visit, or an in-home, an in-office visit. But to say everyone should get some sort of care in the home at all times for all things, that isn't the right expectation to set either. And so I think that's really why you see us thinking about what kinds of care are offered and how do we design those interventions correctly.
Well, and Pippa, burden on the family, right? Like the burden of taking care of people at home. Like I think we've learned a lot with our partners in the ESRD and CKD space of like, I think 7 years ago we were all excited about home dialysis. Home dialysis is actually really hard.
It's hard.
Home PD is also hard, but home HD is a whole different complexity. And like you try to get someone to stick something into their catheter in their fistula. It's like that alone is one challenge, or a big challenge, much less all the coordination, all the other pieces. So I want to make sure we don't lose sight of that as well.
Oh, great point.
I would say that just to comment on the targeting piece and the patient selection piece for a lot of this work, if you think about folks who are quote unquote frail older adults, a lot of work to suggest that perhaps about 50% of preventable costs in the Medicare program live among the frail elderly. Most of that, I think, as Chris and Ali were saying, preventable hospitalization, right? That's where a lot of that savings comes from. We recently did some work. We collaborated with Humana, and we were able to add a few questions to their annual in-home wellness assessment to determine whether folks were homebound. And we had data on 500,000 people. And it turns out in Humana, in their MA plan, about 20% of their population was homebound to some degree. About 8% were completely homebound, basically never get out of the house. Another 12% can't get out of the house without difficulty or with assistance. And when we looked at the independent effect of being homebound on outcomes like hospitalization and skilled nursing facility use and mortality and hospitalization, being homebound was independently associated with all of those things with a very powerful impact on the odds ratio for those things. So, thinking about how to target these things, and I think also we often lack real-time data to truly assess someone's risk at the moment, right? Often it's with looking back on claims or some other data. And I think sometimes that lack of ability to stratify well in the moment becomes a big challenge for what we're up against as well. Let's, if it's okay, I'd like to kind of move on to this notion of, I think inherent in a lot of the comments that you've made, and I heard some hints of it, this notion of what does it take to change the culture of care delivery in big systems, which are, they're kind of like aircraft carriers, right? It is really hard to get certain things to change. And how do we think about, if we're moving towards more home-based care and home-based care ecosystem, and I can tell war stories from my experience in a mid-Atlantic situated health system that I know quite well. But, how do we think about the culture change that needs to happen? Is that going to be driven by startups and now maturing companies like Medically Home, where Pippa is, or does that start from the top at a place like Optum and filter down? Or is it someone like, you, Ali, with all this great experience, and now you're in a payer provider and you can apply all those lessons? How do we actually get, these very facility focused systems to sort of start to rewire, understanding just how challenging that is? What sorts of successes have you seen? Where does that need to happen? Pippa?
Well, I'll start. Thank you. So first of all, they are not beyond hope. So I think that I want to just encourage that. I think sometimes we get really cynical because they are these hulking ships, and it can seem like, and I'll take the blame for physicians. And I'm sorry about my green wall behind me. I couldn't find a room that didn't have a green wall. It turns my face green sometimes. They seem like they can't change anything. What we have seen is that if you can really find the right combination of a clinical leader who actually has some decision-making authority, high enough in that organization, and that they are, and I will say for us, when we think about sort of when we start in the hospital home environment, that has to be started, in hospital medicine, right? So start in the hospital. They can't come from outside. And so when you say medically home, like, we work with the health system, it has to come from within the health system. Unfortunately, they learn from themselves, and they want to see the literature, and they want to talk to everybody they know, and they want to go to the users group, and they want to talk to people at other systems. And so that's thing one, right? Thing two is you have to make it easy, because the work of practicing medicine or being a nurse or working in a health system right now is really hard. Being a PCP is really hard right now. And so can you make it at least at the same amount, but can you make the default, the pathway to getting to home easier, or at least not harder than it is to get into the bricks and mortar? So that's like, if you can do those things, then it starts to be an effect of the first time they do it, they're a little skeptical, right? But then they start to get, we build in feedback mechanisms for all the referring physicians and all the teams that deliver patients. And people start to kind of, and I hope I don't know if anybody, but kind of get religion on this. They see the effect, oh my gosh, the outcomes of this, right? The outcomes are really good. And people start to think about other ways they could treat patients in the home. Now, for the four of us on this call who started from, a realm of primary care and post-acute care and ambulatory care in the home, we already knew this, right? But if you want to get our acute care colleagues in that hospital system world, that's one way to get them. And we have seen that work and that effect start to take hold. And so I think that's really important. And but it's all about, are your processes right? And did you choose the right champions? And finally, is that health system actually committed to decanting their beds? Are they committed that their standard of care is in the home? Because if that's not part of their future business plan, then you're not going to win the game. And we have seen, system after system stand up and say, we are committed to doing this. Our partners and colleagues at the Mayo Clinic said, we built our tower in Florida 2 stories shorter because we believe in our advanced care home program. That is why we did that. And that's a big statement, but that's the kind of commitment your organization needs to have. And then that has helped them think about other programs in the home. And now you see them doing urgent and ED care in the home. They're thinking about cancer care beyond walls, right? For them, it's spread this way. For some organizations, it's going to spread from the primary, it's going to spread different ways for different organizations. But I think that's how you have to start thinking about culture change. And it was reimbursement played a huge role in that. Reimbursement was made easy because of the waiver.
Chris?
So Pippa, I'll take it in a slightly different direction. I have 2 thoughts on culture. One, I think on the provider side, I think there is a lot of pent up culture that's ready to explode into this space, meaning, the provider community, and I think the non-provider administrators in most health systems or large provider groups do believe in trying to find a way to bring care to the home of patients. What culturally needs to change, though, is the predictability of the financial returns. And not that we're guaranteeing financial returns, but that we can build business plans that have, some likelihood of being more than just sort of like guesswork of like inputs of like, if we reduce medical expense and if we improve revenue, then we will be profitable. More like, we believe because we're putting this infrastructure in place, we have these leading indicators that will guide us. We have these ultimate reconciliation methodologies that are stable and agreed upon between the parties. Then I now have a financial planning that is culturally similar to every other financial plan I've ever built. And I think one of the biggest problems we have on the health system side is, you go to a health system, you say, we want you to decant your emergency room, decant your hospital into the home. And, we think, that there's some money to be made here. In addition to, it's the right thing to do. and your administrator looks at you, your CFO, they're like, we're on a 2% margin and you want me to disrupt my units of hospitalization by several thousand. I can't unless you can help me to understand some predictability around this investment financially. So I think that's one thing that culturally has to change. I think on the payer side, Nelly, I'd love your perspective on this. I think one of the other things that needs to people need to be thoughtful about culturally is that many of the payer organizations come to this with a background in remote case management. And so many of our programs, we are taking care of patients. We are at the interface of prescribing medications, ordering labs, ordering X-rays, and if you can't get the payer side of this to sort of really understand that this is different, and the difference requires like a medical group, it requires providing care to patients, and it is not simply sort of like an enhanced case management program. You'll just wind up ultimately kind of pruning out the specialness of these programs that take care of patients well in like a hospital at home program. A hospital at home program is not a case management program. It is a medical program. And I think that is sometimes hard for people. They conceptually, you're like, yes, I understand the words that you're saying, but like a really figuring out how to get them to say like, okay, yeah, we need providers. Those providers need an EMR. The EMR needs to allow for ordering labs and medications, et cetera, is something that also we have to sort of attend to culturally.
Ellie?
I was just grinning. I was like, Chris is listening to all my calls. I was really fortunate at a really pivotal stage of my career after having, spent a lot of time trying to build at Iora to go to CareMore Health Plan. And to see, I think, and much of that DNA lived in Landmark for a long time as well, a model of a plan that, understood its goal in and around really keeping people at home, right? Total cost of care reduction by any means necessary. And we obviously a lot of historic factors, per diem reimbursements and the hospital, stuff like that. But saying at the core of it was a very proactive approach that served as a safety net under a network of PCPs, community PCPs, who we essentially paid to let us do our thing, right? Like we paid them capitation, we assumed that they were not moving their models, right? But we worked in around them. We created the interstitial tissue, and it was led by teams of nurses and care coordinators operating at the top and bottom of their licenses, who, number one, were doing integrated CM and UM, right? They were care planning, and at the exact same time, they're saying, "Oh, you need that nebulizer." I have a standing order from Dr. Khan. We're going to order the nebulizer right now, and it'll be delivered tomorrow, right? Not wait. Let me put in the auth request, right? Or hey, this patient's in the ER, and I can get you an authorization for SNF in the next 4 minutes. And in the meantime, I'll have texted four of our preferred facilities that we work with well, that I was, as a physician, was rounding at 3 or 4 times a week, right? To really, provide the clinical backup to the skilled nursing facility that wasn't necessarily always used to that, right? But like was very welcome to it. And then getting those beds back in 15 minutes, not 15 days, right? Like that kind of integrated care management, utilization management for me has been so crucial at seeing the frontier of what was possible. And like we didn't label, we called it all case management, right? We didn't distinguish it, but it was actually those levers actually coming together in a virtuous way. And when I talk about that vision with our teams of utilization management and care management physicians and nurses at Aetna today, they're bowled over because that is the work that they want to do. But from a health plan perspective, so many of us as plans grew up as commercial plans, right? And commercial plans think on a 1-year timeline, right? What can you do in a year? What are we going to do? How is this affecting our membership next year? Because, people don't stay on a commercial plan very long. There's churn, you change jobs, you change employers, whatever, right? Employer changes plans. And so utilization